welcome to Health Matters, a show about what matters in your health here in Central Massachusetts. Our show is a collaboration between the Worcester District Medical Society and WCCA TV on your cable channel at 194. Thank you so much for joining us for this show. My name is Jay Broadhurst. I'm a family doctor here in Worcester, and today we are talking about a subject which is, I think, difficult for many families and couples in Central Massachusetts, and that is, how do you make babies, and what happens if you have difficulty conceiving children? The topic is generally referred to in the medical world as infertility, and I'm delighted to be joined by three colleagues in this field. To my immediate right is Dr. Katherine Rotker. She happens to be a graduate of the UMass Medical School, and then she went on to receive her residency and additional training in urology. Then on my far right are Dr. Armando Arroyo and Dr. Shaila Chauhan. Drs. Arroyo and Chauhan are both specialists in the discipline of obstetrics and gynecology, and they have been instrumental in bringing infertility expertise to our Central Massachusetts and to the University of the UMass Memorial Health Program. So welcome all.
Thank you.
I'm so delighted that you're here. And I'm going to start by asking Dr. Arroyo or Dr. Chauhan, could you just talk a little bit about who comes to see you? As a family doctor, I have, let's say, a couple I'm caring for. They'd like to have a child. They're having difficulty. I decide they deserve some specialty evaluation. So as a primary care physician, I refer them to you. What happens?
There you start.
Okay, so I can start, yeah. All right, we're at UMass Fertility Center. Mm-hmm. That's where we are now. Our patients are coming to us from the community, from the physicians, and they're referred to us usually after having a difficult time getting pregnant after 1 year. So it's usually...
So the first criteria is you're trying the old-fashioned way for about a year.
A year.
I see.
Yeah. So usually it's been at least a year, and that's when we see them. Most of the couples have been maybe seeing a general OBGYN or primary care, and they've done some evaluation for infertility, mm-hmm. and but nothing has really worked, and then they come and see us. So we start with the fertility testing. That's the first step. Okay. Mm-hmm.
And tell me a little bit about what that involves. How do you evaluate someone's fertility?
Yeah. So the fertility testing is actually fairly simple. It's actually fairly simple because we're focusing on the reproductive system. Okay. So there's just three main parts that are involved in reproduction mainly. It's the ovulation, and the ovaries and the eggs in that area, and then it's the fallopian tubes. Okay. If the fallopian tubes need to be open and normal, and then the sperm, the sperm function, the sperm. Right. So those are the three main parts. Okay. And so the way we test the eggs is mainly with hormone testing.
I see.
Hormone testing. Yep.
Okay.
So
and how does that involve blood tests? Does that involve doing other things? Injections?
Yep. So
how do you evaluate hormones?
It's a very simple test. Okay. It's a very simple test, and it's just a blood test. And the two main tests are it's an AMH. It's an AMH hormone. It's called anti-Müllerian hormone. This is one hormone,
Okay.
and the second hormone is called FSH, follicle stimulating hormone. These are the two main hormones that help us figure out what the egg quality is and what the egg counts are. So AMH is a very simple test to do now, and it's just a simple blood draw, and then we get the results back, and then we can interpret them. And doctors like us, Shaila and I, that's what we spend our time doing, looking at AMH levels, FSH levels, and we know what the averages are, and then we know what's abnormal. So those are the two big ones for the eggs. And then for the fallopian tubes, we do a simple test. It's ultrasound, vaginal ultrasound, and then a water ultrasound test. At the same time, we put a little bit of water in the uterus, and then we can see little bubbles coming out of the fallopian tubes. And if we see bubbles in the fallopian tubes coming out, we know the tubes are open.
I see.
That's our main test that we do in the office.
I see.
And then the third test is for the sperm, and that's a semen analysis.
Right.
And so then we do our semen analysis in the laboratory, we have it come back, we look at the results, and we know that about 15 million sperm is what we're looking for per milliliter. That's what we're looking for. That's the number. And when it's under that, then the sperm count is low, and that could be the reason. And 50% of, 50% of our couples have a male low sperm counts.
I see.
So it's quite a big number, and that's when we refer over to
Dr. Rotker.
Dr. Rotker.
I see.
To evaluate the male.
Okay.
And figure that side out. So that's the basics. Actually, simple, but then gets involved.
Well, it is, and I want to come back to your specialty area, because it sounds like the couple comes to you, but the first two tests that you described are on the woman.
Yes.
And then if the sperm count doesn't measure up to the, how many million?
15 million.
15 million, and that's in something about the size of a drop? Is that?
Per milliliter of ejaculate.
Yeah. Per milliliter of ejaculate. Okay,
Correct.
So Dr. Rotker, let's get into the business here.
Right now, yeah.
How complicated are the male kind of issues in infertility?
Yeah, so infertility affects maybe 15% of all couples trying to conceive. So 85% of couples will conceive by a year, and that remaining 15% are the couples that we're evaluating. I should put a little asterisk. There's many reasons that you might have other concerns, risk factors, and early evaluation could be very appropriate in those scenarios. And for the men, 50% of couples that have trouble conceiving are going to have some male factor. So often it's thought of as a female problem, but that's really not true. It's in a unique diagnosis because it's a couple problem.
Okay. Yeah.
For the male evaluation, it requires a physical exam, a history, talking about some lifestyle choices, and then semen testing, which looks at the ejaculate.
Which is what Dr. Arroyo was, they'll do that and
Sometimes,
send, or maybe not. Maybe sometimes people will come directly.
Sometimes I get men who come directly, concerns about their own fertility. Some couples feel it's going to be easier to test the male first, and then if there's anything, if it's all normal, they'll go on to female.
Right.
Sometimes I get evaluations from primary care physicians for men who have concerns. And often I work with my colleagues where they'll send couples who have abnormalities on initial semen testing to me.
Okay.
So different ways that men can end up on my doorstep.
Now, I'm a family doctor. I'm aware that there are these anatomic differences, that you've got internal organs primarily in women, and it's more of an external kind of situation for men. But is your evaluation involving blood tests and ultrasound and that kind of thing, or?
Yeah, so the initial test for men is, I think, simpler. So it's the physical exam, as you alluded to. A lot can be told by physical exam, history, and semen testing.
Right.
And then depending what that semen testing shows, and there's more than just the concentration or count, we look at how fast the sperm are swimming, the shape and quality of the sperm. And if there's abnormalities on that, further testing is then sometimes indicated. Blood tests to look at hormones are common. Sometimes ultrasounds are required. Sometimes we do further semen testing with a little bit more specialized look at parts of the semen. various tests can be required afterwards, but
Right.
initially it's really the semen test.
So you get lots of data about kind of what the problem is.
Yeah.
But what kinds of things do you find out which, if a man who's listening to us today, and I'm going to come back for the same question about women, but for a man listening to us today, you mentioned sort of lifestyle choices. And I'm imagining that while there may be some issues that run in families, there may be issues that relate to the kind of job a person does, or, I don't know, the clothing that they wear, or whether or not they have to take certain prescribed medicines, or whether or not they use other kinds of substances, their weight, perhaps. So tell our listeners a little bit about the kinds of things that you find and whether or not those are things that our listeners could anticipate and perhaps make choices that promote their fertility as opposed to choices that might inhibit their fertility.
So to answer that question in two parts, I generally, one of the lines I say to my patients a lot is, things that are good for you are good for your sperm.
Oh.
So we all know a bit about what healthy lifestyle looks like. Eating plenty of fruits and vegetables, not drinking excessively, avoiding cigarette smoke, and there's some data as well on marijuana use and sperm quality. So sort of things we know that are important for our health, maintaining a healthy weight, regular exercise, have all been shown to be important for sperm quality as well. So in terms of things we can do to improve our sperm quality, number one is live a healthy lifestyle to the best of our ability, and that's reflected in our sperm.
Okay.
And then from a bigger picture, what are some of the causes of male infertility? Sort of what do we end up finding? There can be anatomic issues. So one of the most common reversible causes of male infertility is varicoceles, or dilated veins leading to the testicles.
Okay.
It can be genetic issues that we find. There can be hormonal issues. As you alluded to, certain medications or treatments, chemotherapy for cancers,
Sure.
Testosterone placement can all affect the ability to produce sperm.
Okay.
And then there are exposure histories, whether that's from lifestyle choices or the job you work, high heat environments, all can affect sperm production. So a wide variety of things we're looking for in that history and physical.
Wow. It sounds like it gets a little complicated.
It can, but at a very basic level, we're looking at that sperm for quality and cause.
But I love that sort of general advice. What's good for you and your health and well-being, generally speaking, is good for your sperm.
Correct.
So let's go back to the female side of the equation. And Dr. Chauhan, I wonder, from your perspective, having heard some of the things that men encounter, what are some of the things that the women patients that you see, what are some of the things that they encounter that that might be related to their infertility?
You mean about the lifestyle?
Well, Dr. Arroyo gave us a good sense of the pieces that are needed. You've got to have eggs, and you've got to have a fallopian tube that works to get the eggs into the uterus. But, you know, that's kind of anatomy. And I wonder...
Well, one of the additional comment I'd like to make is for infertility, if someone is over 35, we ask them to come earlier, like in 6 months, just because their reproductive life is going to be shorter. And so we like them to get to us so we can get them pregnant, because fertility does go down after 35. So although by definition it's a year, for people or women over age 35, we consider 6 months is enough. That if they are not pregnant by 6 months, they should actually come to us.
You know, that raises kind of an issue from my point of view. When would you say is optimal fertility time for a woman? From when to when?
Actually, the younger they are is better.
Well, right. That's what I thought you might say.
Right.
But
so
we're not encouraging 15-year-old women to get pregnant, right?
no, but between 25 and 35.
Okay.
We would like them to conceive at least one time, and I'm sure if they want to have another child, they still have to have the time.
Right.
Even the patients that we treat, you divide them age-wise, the pregnancy rate is much higher if they are less than 30. Between 30 and 35 goes down a little bit. After 35 goes, quite. And after 40, it's a steep slope. So
I see.
we really like to get the patients in early so we can give them the happiness that they need.
I see. Let me just take a moment and remind our audience that my name is James Broadhurst, and we're speaking with 3 experts about infertility, both male and female. I'm joined by Dr. Rotker, Dr. Arroyo, and Dr. Chauhan. And Dr. Chauhan, I was wondering if you could maybe describe some of the issues or perhaps some of the
Causes.
Interventions that you can, you've got a couple, they'd like to be pregnant, it's not working. How do you actually translate that anatomy into helping a person get pregnant?
So about 35% of patients we see actually do not ovulate. So they have eggs,
Right.
but they don't mature. Unless the eggs are mature, they don't ovulate.
So that means they're getting released by the ovary
Right,
in
right.
order to get in a position to get pregnant.
So the
be
eggs
fertilized.
have to be released out of the ovary to
Right.
be able to fertilize by the sperm, which happens in the tube. And then the tube, once fertilized, grows the eggs for about 3 days, and then it'll come to the uterus, and then it attaches or implants.
Right.
So
Got it.
any abnormalities will cause infertility. So one, if they don't release an egg, that's about 35% of women that does that. And it's fairly easy to treat that. And most of these patients will come to us when they are younger. So the pregnancy rate is pretty high.
I see.
Then there are patients who may have problem with tubal disease. The tubes may be blocked. That's about 15 to 20% now. It's not that high, but it is there. And those patients cannot get pregnant unless the tubes are open, which has a very poor outcome.
So how do tubes get blocked?
There are insults like diseases, like STDs will block them. Sometimes they've had surgeries for other problems,
Right.
and they can form scarring in the abdomen that will cause, like patients may have appendicitis and rupture the appendix before they operate, and that would cause a generalized
Because of the infection in the
Infection
neighborhood
and, yeah.
could affect. So one of the things is that as a woman is growing up and maturing and becoming sexually active, if there are questions about infection, it's really a good idea to get those checked out, by your primary care
Yes.
physician and have those treated so that you don't wind up with this kind of a problem later on. which-
Right.
I see. Okay. Fair enough. I'm sorry. Carry on.
So the other problem could be where we do the testing and we can't find any reason. We see at university, of course, we see much higher number of those women because they've gone somewhere and not gotten pregnant because they don't have the primary OBGYN, do not have advanced techniques that we could do. But
Right.
those patients are given the diagnosis of unexplained infertility, which is actually no diagnosis. We can't tell
Right.
why they can't get pregnant. And those are the women, it's difficult to get them pregnant. But we do have good pregnancy rate with the medications, and we also do inseminations, which is another treatment which we start with. We usually will give them medication. Even though they ovulate, we give them ovulatory medication, supposed to make them more fertile
Right.
during that cycle. And then we coordinate the cycle by making them ovulate on time, and then at that time of ovulation, we actually take the sperm,
Right.
process it, concentrate it, and put it inside the uterus, so as to save part of the journey of the sperm from the vagina to the uterus that we would do.
Right.
So we hope that they will find their way to the egg in the tube.
Right. You sort of set them up to be in the best possible location to find their way to...
And I always joke around, they come from men, and men don't like to ask for directions. So we give them directions.
I see.
To get
All
there.
right. Fair enough. Dr. Rotker, there was something that Dr. Chauhan just said about the fertility balance, and I know I wanted to turn to you at the moment and just say, well, how does this semen get? How is that involved? And I'm not remembering the specific question, which disturbs me, but was there anything in her description that you felt, was applicable to men?
Well, I think one of the things I talk about with the couples, because again, this is a couple issue. We share couples, we talk about these couples, is that there's 3 ways women are going to become pregnant: natural conception, intrauterine insemination, which is the technique that Dr. Chauhan was just beautifully describing, and then in vitro fertilization. And with male factor, one of the roles I think I play on top of evaluating the sperm is to help a couple in the male aspect determine which of these methods they're going to require. And sometimes none of those methods are going to work from a male factor standpoint, and things like sperm donation or adoption might be the right choices for a couple. But again, my role is to determine maybe the best methods for the couple from a male aspect, and then with our new center, not only is intrauterine insemination an option, but in vitro fertilization, and that's part of what we wanted to highlight today in this new center.
I appreciate that, and perhaps, and I don't know which of you two would like to take the lead, but I'm eager to learn more about this new, I think it's called an IVF center, but there may be a different name, IVF standing for in vitro fertilization. But tell our listeners about this new center at UMass and what it has to offer.
We are excited to have it. I've been at UMass for 15 years, and I've had this dream for all these years, which is now coming true. So we are very excited about it, and we have a lot to offer. Now IVF is becoming a very treatment for any infertility. Anybody who does not get pregnant is the end of the road where we can do IVF. And we are lucky in Massachusetts because it's paid by insurance. So it's fairly easy for the couples to have it, even though it's an expensive procedure. And there are a lot of indications that lead to in vitro fertilization therapy. So,
are there times when you'll be evaluating a couple and you'll decide that it's appropriate to skip over some of these earlier interventions that we've discussed and go straight to IVF?
Yes, when patients have blocked tubes.
Right, okay.
Those will be the patients who have much higher rate of pregnancy, and that's the treatment for them, besides surgery, which is not as successful as IVF.
I see.
And so that's one. Patients who have unexplained infertility sometimes do much better with in vitro fertilization. There are women who are older. We would encourage them because in vitro fertilization has much quicker pregnancy rate.
Right.
So if you compare the other modalities and IVF gives you much quicker pregnancy. The pregnancy rate is not as high, but it's much quicker, and that's when you're older, we are fighting time.
Right.
And that's very important.
Well, that was the question, because I remember you're saying that once a woman gets to age 35, fertility declines. That was the question I wanted to ask you, Dr. Rotker, was what about men? Is there a prime, Dr. Chauhan was saying that, kind of earlier in a woman's life, fertility is better, although we're not wildly enthusiastic about people who are 15 being pregnant, but 25. Is there a prime fertility age for men?
So for a lot of years, we sort of thought that men could reproduce forever, that there was no prime, that you could be 85.
Even me?
Sure.
Oh, sure.
Have at it. There's a lot more data coming out that there is now what's called sort of an advanced paternal age. So that's sort of a term we use for advanced maternal age and the risk factors that come with being an older mother.
Right.
And that there is now more association that there may be certain conditions more prominent in offspring of men who conceive after the age of 45. So there's a bigger window, but
I'm outside that window.
we'd have to talk about the risks.
That's fine. Right. I appreciate that. So I'm going to leave some time for additional services, but I do want to ask each of you to comment on the fact that not every couple is a traditional couple. We've sort of talked around the fact that it's a man and a woman, and that works well. But there are same-sex couples who are interested in having children. And I wonder how those groups of folks are cared for within the center or within the Department of Urology. And would you be willing to comment briefly?
Do you want to comment on that?
Sure. So same-sex couples, we see a good percentage of our patients are same-sex couples.
Right.
And, usually it's two women. Mm-hmm. And that's generally, the group.
Right.
And it could be two men also, though.
Exactly.
Yeah, it could be two men also. And so two women, and so there, we need sperm. So
right.
So we need sperm, and the general treatment is insemination.
Okay.
Intrauterine insemination with donor sperm. So
well, it turns out our time is just run out, and I apologize because there's so much more that we could be talking about. I want to thank Dr. Arroyo and Dr. Chauhan and Dr. Rotker for coming and sharing your expertise. And I also want to thank Gus Sanchez, our cameraman, Melinda Boucher, our worker from the District Medical Society, and to Frank Rocco, our engineer. And I want to thank you, our audience, for joining us on this issue of Health Matters. We'll see you again next time.